Dr. Pelayo is here to help us because most of us just don't take sleep medicine seriously. Basic sleep for the healthcare provider. Thanks for coming back, Doctor.
Thank you so much. Thank you. I noticed in the program that you guys got 45 minutes for lunch, but I have an hour to speak to you, which really means that the organizers value sleep over food, and I like that. That's really important because it is true. You can go more days without eating than you can without sleep. Think about it. You can go a lot more days without eating than you can without sleep. The record for lack of sleep, I think, is 9 days. It's no longer quoted. It's no longer. It used to be published in the Guinness Book of World Records, but they stopped publishing it because they thought it was not a safe thing people to try to break. But that's been going on for a while. And it is true what Dr. Khan said. Thank you so much for inviting me. It's true what he said that pretty much my first week of medical school, I decided to pursue sleep medicine as a career path. But now, in retrospect, I realized that it made me ignore cardiology and a lot of other things that I probably should have focused on more on. So I was actually kind of nervous about coming back to you for a cardiovascular conference because you guys are the real internists, you're the real physicians. But thank you for inviting me. Let's talk about some stuff here. So these are the things we deal with. These are the things we can talk about. Insomnia, and with an S, a lot of different variants of insomnia, sleep apnea. There's parasomnia, things that go bump in the night, and sometimes I do some medical legal work with crimes that have occurred related to sleepwalking and things in the sleep field. Restless legs, narcolepsy. There are so many, sleep disorders are so common, it's impossible that a group this big, there's not somebody here, or several of you have sleep problems. In fact, any given night, half of us don't think we slept well, right? How many of you slept well last night? I did. Well, how many of you didn't sleep well last night? Raise your hands. Damn it. So that explains this thing, right? I noticed that. I've been to many conferences, but this is the first time I see you guys handing out the energy drinks before. I've never seen that before. That's like, I've never seen that they've done this. Crazy. So I'm taking it with me. Thank you. All right, so let's talk about this. So I thought we'd just talk on insomnia. The reason I want to talk about insomnia, and I know in cardiovascular you're more interested in sleep apnea. We'll talk about sleep apnea for sure. I'm also doing some advocacy work on behalf of high school students and junior high school students in California to change the school start times. So I've been to Sacramento 3 times now to testify there, and we can talk about that. But the reason I like talking about insomnia, and I know you go, we'll talk about sleep apnea for sure, but the reason I like talking about insomnia, because insomnia encapsulates normal sleep physiology. And so if you understand how insomnia works, then normal sleep will make more sense for you. So how do we get insomnia? How does it become chronic? How do we fix it? There are these different stages of sleep that we always talk about. And you've heard about this before. You've heard about light sleep, deep sleep, stage 1s, REM sleep. But when we talk about sleep and the sleep stages, I realize the patients are saying something different, and I want to make sure that we're on the same page. So when we talk about deep sleep or delta sleep, we're talking about the first third of the night, it's about 10% of the night, stage 3 we call it now, slow wave sleep. But a lot of times the patients, when they say I slept deeply, what they meant is that they were dreaming. They equate dreaming with deep sleep, and dreaming is not such a deep sleep. Dreams, though, dominate the last third of the night. The bulk of our sleep at the last of the night is dreaming sleep, or rapid eye movement sleep. And we have about a rapid eye movement sleep episode, which is, by the way, when we dream. And we can talk about dreaming. If you guys are interested in talking about dreaming, we can talk about that too. Why are you laughing? Really? Really? I mean, thank you. But, we can't talk about dreaming. It's an interesting topic, right? I think dreaming is interesting. Why do we do it? But we dream about a third, we dream about every 90 minutes. And the dreams get longer, more intense, and more vivid as the night goes on. So you get your most vivid, most intense dreams in the last third of the night. And we dream for about an hour and a half to 2 hours every night. But we don't remember an hour and a half or 2 hours of dreaming every night. And some of the new ideas about the functions of sleep and the functions of dreaming actually tied into memory processing, memory consolidation. And there's been an increased interest in the sleep field among people who do work with dementia and neurodegenerative disorders. But dreams dominate the last third of the night. So if you look at this, let's see if this is working. That's the last of the night. If you wake up early, what are you cutting off? Your dreams. And how many times have you heard this simple platitude? I want you to follow your dreams. Follow your dreams. We talk to our kids, follow your dreams. But what do we do to them? We cut off their dreams. That's exactly what we're doing. We're really cutting off their dreams. And when somebody doesn't get enough sleep, the first evidence of lack of sleep is people being a little bit irritable and a little bit inattentive. How many of you wake up next to somebody who's inattentive and irritable? It's lack of sleep. And people grabbing coffee first thing in the morning, which hypothetically you shouldn't need coffee first thing in the morning. Because what caffeine does is block adenosine. Adenosine builds up in our brains as the day goes on. So actually, when we first wake up, our brains are full of ATP, adenosine triphosphate, and our adenosine level is low. So if you need coffee first thing in the morning, something's wrong. You should never, ever wake up feeling tired, right? How many of you wake up tired? I don't wake up tired, right? I mean, does that make any sense that you wake up tired? Makes no sense at all, right? Why should you wake up tired? It just doesn't make any sense. You should wake up feeling refreshed, right? How many of you left lunch feeling hungry? None of you, right? Doesn't happen. You know, it's amazing speakers here, by the way, really good folks. And I heard the keynote, Dr. Levy, and you know, when you hear these talks, and we have this bias, and we think, well, I know what I learned here, and I kind of know the topic already, so we hear what we want to hear. And what I heard from his talk is that I can lose weight if I take up cigarette smoking. And I thought I could do that myself. That's what he said. That's what I was thinking. That's what I heard. Then I left. He didn't say that. That sounded like that to me. Like the lowest weight for smokers. But the thing about sleep that we don't understand, that we often look, is that nobody here slept 8 hours at night. Nobody sleeps 8 hours at night. Nobody sleeps through the night. That's a myth. We actually wake up about every 90 minutes. And every 90 minutes, all humans open their eyes, make sure everything's okay, and we go back to sleep. You will never, ever sleep throughout the night. Lions and tigers would have figured that out a long time ago. They could pick us off in our caves. All humans, at the end of every REM cycle, we have the major body movement. If we weren't doing these movements and these brief awakenings, we'd have bed sores, right? About every 90 minutes, all humans wake up, look around briefly, just watch anybody sleep, and then watch when they wake up. Open their eyes briefly, scan the room, back asleep. You only wake for 15 or 20 seconds, but we wake up about every hour and a half. And about 10 times per hour, our brain waves look like we're awake for about 3 seconds. There's an inherent paradox of sleep, and many of our patients, many of us are trapped in this paradox of sleep. We talked about the obesity paradox earlier. But there is a paradox of sleep. Animals have to sleep for reasons that are not entirely clear, probably multiple reasons for it, and we can talk about that if we have time. But we have to sleep for reasons that are not entirely clear. The earliest sleep research, they sleep-deprived puppies, and they would sleep-deprive puppies to the point of death. And they die of sepsis, by the way. That's what they die of, if you sleep-deprive them. So I forgot where I was going with that. I was going to say something important. What was I just saying about that? What? Waking up during sleep is important, right? So the paradox of sleep, thank you, is that sleeping is inherently dangerous to all of us, okay? But you have to do it. So how do you have a situation where you could be attacked at any moment? You would think that animals are most vulnerable while they're sleeping, so animals must protect themselves while they're sleeping at all times. And that's what happens. When we're sleeping, we protect ourselves. And in humans, we have this awakenings about every 90 minutes. And they've actually done this. They've looked at hunter-gatherer tribes in pre-industrial societies, and they monitor their sleep. And they find a tribe of people, they've done this in several tribes already, they all go to bed around the same time, and they all wake up around the same time. But throughout the night, members of the tribe are awake at different times. There's a protective effect to this. So again, sleeping through the night is a misconception. It just means whether you're aware that you're awake or not. So when you talk to your patient, they say, I wake up. You say, that's good. That's the issue. It's not that you wake up, it's you have trouble going back to sleep. And that's what you have to focus on. In the end, when we take care of patients with sleep disorders, what we're really taking care of is not people who have really, they don't come to us because of their sleep. They come to us because how they feel when they're awake, which they attribute to their sleep. So any conversations on how to help a patient better has to always focus on how they feel when they're awake. If it didn't bother you to stay awake, you wouldn't be complaining, right? The issue is that you feel it affects you the next day. To pull my hair out over this, I don't want people to just equate sleep medicine with sleep studies. If you're just working with your sleep doctors locally and just getting a test, but you're not getting a consult, there's some value to actually getting a consult. There shouldn't be just a test at all, right? You gotta think about what you're dealing with. But oftentimes, you want that physician to spend time with your patient. I spend about an hour with every patient. That's how I do it. We don't really cover much sleep in your medical training. So I want to give you just a quick outline how to think about any complaint about sleep. If somebody complains to you about their sleep, Every sleep complaint has 4 components. So when you get the history, just go over these 4 things really quickly as you speak to them. Obviously, the first one is amount of sleep. How much sleep did you get? And people often stop on just this. How much sleep did you get? Right? And I told you this last time. Parents, because I work with kids, parents always ask the same question. How many hours should my child sleep? And what they're really asking you is how many hours can I be away from this person? That's what they're really asking you. That's what they really want to know. Right? That's what it's about. So the amount of sleep is important. We should get about 7 to 9 hours of sleep. That's where we are. But if you talk about the amounts of sleep in any one person, there's just some seasonality to human sleep, and most of us have 2 numbers in our head when we talk about your sleep amounts. Most of you will say things like, I like to get 8, but I can get by with 7. Or I like to get 7, I like to get 5.5. You have these 2 numbers in your head. And that probably has to do with the change of seasons. And there's some seasonality to human sleep. People certainly sleep more in the long winter nights. In Alaska, people sleep more in the winters, and they sleep less in the long summer days. The amount of sleep is important, but the quality probably just as important. I don't know if I told you this last time I was here, but I had a 3-year-old. And I remember this kid really well because most of the time when you talk to kids, I work mostly with adults, by the way, but when you work with kids, they give you very clean histories. They're very pure the way they speak. And usually if you get a 3-year-old to come to you, you ask, like, any patient, why are you here? And usually, the kids hide behind the parents, they don't make eye contact. But this little kid looked at me in the eye and he said, doctor. He said, doctor, sleeping makes me tired. And I'm like, whoa, that's a very insightful thing to say. And he just had big tonsils, so the more he slept, the worse he was gonna feel, because the less he was breathing. By the way, this also happens to you when you prescribe medications for their sleep. Some people say that, I took this medication and I felt horrible the next day for a long time. Well, if they have undiagnosed sleep apnea, the more they sleep, the less they're breathing. So sometimes they're feeling poorly, not because of the pill itself, but because they slept longer than they used to and they were choking in their sleep the entire time. So you have to think of it a little bit that way. So the amount, the quality, and what's next? The timing of your sleep. Are you a shift worker? Do you work nights? Different times? For a long time, we've been, the sleep fields wanted cardiologists to pay attention to us, and it's been happening more and more, so I'm really happy to be here. But today's the first time I actually heard a cardiologist talk about sleep in teens. That was kind of cool to hear that. But one of the things he talked about was the amount of light that they're getting, the blue light. Turns out that that's not as true as we think it is, actually. The light there are these photoreceptors that can affect this, so in research, the lights actually do shift how you're doing. But in real practice, it doesn't really make that much of a difference, because what's more important to the person is not the light. The light's not shifting us. It's the content, the activity. That's that interaction. So they've not shown that filtering that blue light really changes the behavior of the kids, because it's the interaction in of itself matters more. Yes, we want to diminish screen times, but these sleep disorders and these sleep problems we're saying in young people have been occurring way before the cell phones were ever available. This has been going on for a long, long time. So yes, blue light's important. But it's not fair to scapegoat the kids and just say, just put on the blue blocker or sunglasses and it'll be fine. They're still interacting with the devices, and that's what's keeping them awake. So the amount of sleep, quality of sleep, timing of their sleep, and ultimately the most important thing is your state of mind. Do you look forward to sleeping? Is sleeping a hassle for you? Do you dread going to bed at night? Do you look forward to your day? Right? Because why do we sleep in the first place? Do we live to sleep or sleep to live, right? The idea, you have to think a little bit about your patient, what's going on. And especially with insomnia, since people with insomnia may have depression. Right? Suicidality is a real issue that we have to deal with. But for the most part, people should look forward to sleeping, right? And think about yourself right now. Do you dread the night? How many of you try to fall asleep before your bed partner does because that person snores, right? Or how many of you wait for your partner to fall asleep before you get into bed because you don't want to deal with that person, right? There's all these dynamics that go on. A lot of issues happen. The need for sleep is biological, but the way you sleep is learned. That's just simply a true fact. We are taught how to sleep. Sleeping is a learned behavior. You've been taught how to sleep. It's just like food. All newborn babies drink milk. 5-year-olds throughout the world have different diets. The need for food is biological, but what you eat is cultural. Sleep is the same way. All of you have been taught how to sleep. All of you have learned to sleep a certain way. Those of you who have regular bed partners, remember the first night you slept next to that person? You had one side of the bed, that person had the other side of the bed. The next night, there was no conversation. That became your side forever, right? Right? It is. Right? That is your side forever. And in fact, if your partner is out of town and you dare sleep on their side, they view that as an invasion of privacy. You used my pillow last night. How dare you? I've done this, right? And this goes on all the time. And if you don't believe me that sleeping is learned, simply rotate your body where your feet normally goes, in the bed, and see what happens to you. In the same bedroom, same everything, you'll feel unsteady. You may even fall out of bed if you do that. And I've learned that people kind of stick to the side of the bed for a long, long time, forever, pretty much. When they travel, they know what to do. The only time people switch sides of the bed is older couples, I've learned. If one of them has to go to the bathroom more often at night. And then when they travel, they have a deal that whoever's going to sleep closer to the bathroom. That's the only time they switch sides. Some of you, so you can look forward to that, some of you. So chronic insomnia is a real, real problem. Fatigue, malaise, just not happy. And it's something you have to do every single night. People with insomnia really, really are suffering. It's not a good experience. And the problem is the treatments become an issue. One of the things you'll encounter, I don't know if it happens in cardiology in general, but definitely with the sleep patients, especially with the insomniacs, people with insomnia blame themselves. If only I was a different person, I could sleep better. So they guilt trip themselves. If only I'd worry less. There's something about me that's bad that makes me sleep this way. They beat themselves up over this. And they said every night they have to do this. Every night. And then when it gets really bad, people with insomnia talk a certain way that only insomniacs talk. The only people who ever say the phrase, I try to go to sleep. Everybody else says, I go to sleep. You don't try to get hungry, right? Why should you try to sleep? You can't do that. The only way you can try to sleep is by staying awake. Or if you get trapped into thinking, tomorrow depends on how will I do tonight. How will I do tomorrow depends on how will I sleep tonight. Then how do I know what kind of day I'm going to have tomorrow unless I monitor my own sleep by sleeping as lightly as I can? And you sleep even lighter and lighter. So the sleep gets worse and worse over time. The other thing to know about sleep is it's very sensitive to placebo effects. Extremely sensitive to placebo effects, like a 30-something response to placebo. Everything works in the beginning. But if you don't deal with the underlying cause of insomnia, whatever they use will stop working after a while, and then they do something else. So you see them, they begin with earplugs or a special pillow, and then it's a special mattress. And this goes on. And you see people when they travel in the airports a lot, carrying their pillows with them. Why are they doing that, right? So it's a tough thing to deal with. A lot of famous people have insomnia. The thought of sleeping wakes them up. This is the model we use to explain chronic insomnia. You can use this model for lots and lots of different things. Some people are more predisposed to insomnia than others. Women are twice as likely to have insomnia as men. It's a true thing. Men snore more, women have more insomnia. And when you deal with children, little kids and little boys and girls, when they're little, they have just as much as insomnia. There's no difference between the biological sexes. But once puberty begins, the girls start having more insomnia than the boys. In fact, the Center for Disease Control has measured this. Girls are much more prone to not get enough sleep than teenage boys are. It's a known thing. And all of you know that you may have menstrual-related changes with your sleep. After menopause, women will sleep poorly. During pregnancy, women may sleep poorly also. Something comes along to trigger a bout of insomnia. Good news or bad news, anything can trigger a bout of insomnia. For most of us, if you have a bad night of sleep, you're just excited about something's going on. That's cool. And that might keep you awake. It could be something. I don't sleep well, for example, if I have to catch an early morning flight, especially if I'm at a hotel, right? I just know. I often wake up before the alarm clock because I'm just anxious about traveling. But what we deal with in sleep medicine is not the predisposing factors or the precipitating factors. The trigger can be passed. We typically see people with insomnia for 15, 20 years after they've had insomnia. You see a 70-year-old who said it began in her 50s. That's very, very common, what we do. What we deal with is what's driving the insomnia, what's the perpetuating factors. Because sleep is a learned behavior. And if you've ever slept well, the ability to sleep remains intact then. It's very hard to pick off the wiring from a neurological point of view. It's hard for you to damage your ability to sleep. The sleep part of the brain that deals with sleep has a really good blood supply. It's right around the circle of Willis. So most people can sleep better. And that's the good news about sleep. I told you there's a paradox of sleep. We all have to sleep, but when we're sleeping, we're vulnerable to being attacked. So the ways of protecting our bodies and protecting our souls while we're sleeping. But also, if any of you have had poor sleep, the good news is if it's addressed correctly, it should be able to be improved upon. It's unusual for one of our patients not to get better. It's unusual for them not to improve. The stuff about sleep hygiene you hear about doesn't work. I'm on a kick not to say the word sleep hygiene. I have the other speaker said you had 2 books. I only have 1 book, but I have another. I signed a book contract, actually, in March. So I have a book that will be coming out called The New Rules of Sleep. And it's specifically to talk about sleep hygiene because it's never been shown to work. Sleep hygiene is just good for everybody else, but if you talk to insomniacs, it just doesn't work. It's like telling somebody who's anxious, relax. It doesn't work. It doesn't happen. So it's never been shown to work for people with chronic insomnia. There's no paper showing that it works. But it's often talked about. It's a very successful term. Actually, it came from the Mayo Clinic, from Dr. Peter Hari. Let's talk about hypnotics briefly, because I want to move along. What was in the news just this week, you guys saw it, there's now a black box warning on all hypnotics. Actually, not all hypnotics, I apologize. For the main ones, the Zolpidem, Zolaplan, Zobaclone, you're familiar with the brand names, those are the typical ones you'll hear about. There's a black box warning about unusual behaviors in terms like sleepwalking, sleep eating. Anything that you can do, anything that you've overlearned, anything that you know how to do really well, you can do in your sleep. Anything that's overlearned. So couldn't you in your sleep, couldn't you, if you're blindfolded, put your key in the ignition and turn on your car, shift the gears? You could do that, right? You wouldn't drive it too well blindfolded, but you could kind of maneuver it for a little while. Anything you can do. People eat. We eat all the time. People can sleep eat. So these behaviors seem to be enhanced with these medications, but in fairness, now there's a black box warning on them that I think just came out this week. Usually what happens with hypnotics is that people, when they do these weird things, they've taken the medication incorrectly. And what happens is these medications overall have been very safe for a long time, considered at least safer. Hypnotics have not gotten more effective over time. They've gotten safer. In the 50s, we had barbiturates. People talk about Marilyn Monroe and these people dying of overdoses. And all of you can quote maybe Heath Ledger's death. And you can think about Michael Jackson's death, propofol, right? There's a lot of things people have used to sleep, but they blame the medication. But you really got to blame the insomnia. It's not the pill, it's the insomnia that drives them to do this. People with insomnia don't want to take medication. They feel they have no other choice. They have this double-edged sword for them where they feel like, damned if I do, damned if I don't. And if they take medication and they sleep better, now they feel trapped. Because when do I stop? And then if you prescribe them as a clinician, you have the same question. I'll give you some medication, but when do I stop? And now with the databases and the federal stuff that we're dealing with, it just becomes more of a hassle. It's become more of a hassle to prescribe medication for our patients. Patients often will take the pills too early. The right way to take a medication, if you're going to prescribe hypnotics, the right way to do it is you ask somebody to go to bed later. Biologically, all of us, I'm talking about the timing of sleep earlier, all of us are more awake at night than at any other time. Your peak alertness is in the evening. When are we most likely to be attacked by our predators? At night. When are humans most alert? At night. You'll notice yourselves after lunch getting a drop in alertness and you'll blame your lunch, but dinner doesn't make you sleepy. So it's not the food, it's a biological time of the day. So in the evening, before we're gonna go to sleep, when we're vulnerable, what should we do? Be very alert and make sure everything's safe for us to go to sleep. So we go from a peak alertness to our deepest sleep. Slow wave sleep dominates the first third of the night. So we go from really high awake, slam into our deepest sleep, and then we start oscillating after that. So since we have this surge of alertness in the evening, you'll notice this yourselves. Right now, you've had lunch, I might be boring you, that's okay. But if you manage to stay awake, this evening you're gonna perk up. Right? How do you explain that, right? That doesn't make any sense, but there's a mechanism in your brain to perk you up. So if you take the sleeping pill when you are not expecting to, let's say you normally go to bed at 10 o'clock at night, but don't fall asleep till midnight, the doctor gave you some medication, you go, oh, I'm gonna take my pill early tonight, take it at 9:30, or I'm gonna take it at 10. Well, you're swimming upstream because the brain doesn't expect to be asleep yet. It's gonna resist it. And if you do this with somebody in a special needs situation or somebody in a dementia situation, anybody, what can occur is that when you get in between awake and asleep, you start to hallucinate and they get freaked out. And people tell you things like, my child had an abnormal reaction to medication, or I felt really weird. And whenever anybody tells you that they've hallucinated on sleeping pills, your first thought may be, were the lights on? Because you need to have the lights on to hallucinate. And why are the lights on if you're taking a sleeping pill? It doesn't make any sense. The right way to prescribe medication, if you're gonna bother doing it, is you have the patients go to bed later. So let's say I don't normally fall asleep till midnight. When you deal with teenagers, they have trouble falling asleep. When you deal with adults, they have trouble staying asleep. Right? You'll say, I have no trouble falling asleep, I have trouble staying asleep. So what you have them do is go to bed later. You always do the same thing. Go to bed later and then take the pill. Also, most of these hypnotics are meant to work better on an empty stomach, and that often gets overlooked. They don't know that. Have a snack. No, if you go to bed later, you take the pill then on an empty stomach, and now you're going in the right direction. The other thing you'll see, some people are scared of the pill because they're scared of being addicted, so they underdose themselves. When you underdose yourself, then you're more likely to be disinhibited and do weird things. Actually, this does happen. People thinking, this happens a lot. People say to you, doctor, my problem is I can't turn off my brain. How many of you heard this before? So you say this yourself, right? The brain's not meant to be turned off, right? You turn it off once, that's it, right? You don't turn off your brain. The sleeping brain is a very active brain. In fact, some parts of the brain, particularly like when we're dreaming, consume more glucose and have more blood supply when you're sleeping than when you're awake, right? For you to see me, I have to reflect light to you. For you, God forbid, have a dream about me, you would have to create that image. It requires more energy. So the brain actually consumes a lot of energy simply trying to dream, especially the later part of the night. So please keep these things in mind when you're dealing with these hypnotics, okay? Patients take the medications the wrong way. The Academy, which one was this one? The Academy of Sleep Medicine has a position paper on all the hypnotics, and they find that all of them, the evidence supporting their use and not supporting their use is relatively weak. But you can take a look at this. You probably have this slide, or you have access to it. A lot of the things you're prescribing actually have no evidence showing that they work on a sustained basis, like trazodone, diphenylhydramine, that's Benadryl, right? Diphenylhydramine, it'll make you drowsy, but it wears off if you take it every day for about 2 weeks. For chronic insomnia, we're talking about chronic insomniacs, not I've got the flu and I'm going to stay home tomorrow, then yeah, sure, take some diphenylhydramine, stay in bed. That's different. But chronic insomniacs, and by the way, we define chronic insomnia as having poor sleep 3 times a week for more than 3 months. So most people, by the time they come see you, they've already been waiting more than 3 months. So we're dealing with chronic insomniacs. No data showing that these things works. Melatonin, by the way, is the hormone that tells the brain that night's approaching. Melatonin does not make us drowsy per se. It simply clues you in that night's approaching. Nocturnal animals, rodents, they have elevated melatonin in their brains at night also, but to them, the melatonin means night's approaching, get busy. So it's just signaling that night's coming. That's what that's supposed to be doing. And melatonin is the receptors of the melatonin are suppressed by light. So if you're eating melatonin, but the lights are on, it's not going to work anyway. The research on melatonin is always on the dark light conditions. That's why in real world situations, clinical trials, it doesn't really show to work. And what's happened clinically also, if you've got a patient who's happy taking something over the counter, they're not going to come talk to you about their sleep. They're happy with whatever they found. So you're also going to have the referral bias of the people who come see you who have these issues. So how do we treat insomnia these days is with behavioral treatment, cognitive behavioral therapy. That's good news. That's how we're doing it now. You can look at how this is done. How are we doing for time? Is my time over? My countdown says 0. It does. I'm not kidding. Sure? Okay, I'll keep talking. Is that okay, Patty? You're the next speaker. Sure. Okay. You're not sleepy. Ha ha. Never heard that before. You know, I don't know if you can tell, but at lunch, I don't like to eat lunch before. I don't like to eat before I speak, so I didn't eat the lunch, but I did have some tequila because I figured there's no carbs. And I thought it was the 5th of May today, so I was close enough to pretend it's actually the 4th of May. But anyway, that's what I did. Yeah, that's true. They were nice enough to let me get something at the bar that was closed, but they opened it for me. So there are these real techniques. There are real techniques to help you sleep better, behavioral techniques. The one that you can do if you're having racing thoughts. How many of you have racing thoughts? Idea of racing thoughts? Scheduled thinking time really works. For a lot of people, the only time they're alone with their thoughts is when lying in bed. And I got to do this, I got to do that. And you give your body mixed signals. I'm laying in bed, I want to think about what I want to do, but I want to sleep at the same time. You give your body mixed signals. And that's why sometimes you have your body kind of misfire. You're lying in bed and all of a sudden your leg jerks out from you or your legs flinch. That's called the hypnic jerk. And that's because you're trying to sleep, but you're also trying to stay awake at the same time. You're trying to think, I got to do this, I got to do that. So what helps to that is actually spend time. If you do have an insomnia sleep problem, we give you later bedtime because you want to consolidate your sleep. People with insomnia are very inefficient sleepers. They say things, if I'm lucky, I get 5 hours. Well, you spend 9 hours in bed when you get the history. What do you do the other 4 hours? I rest. Because they equate resting with sleeping. And resting and sleeping is not the same thing. So we have people spend less time in bed. We give them later bedtimes. It's easier to force yourself to stay awake than force yourself to fall asleep. So the way we do it is we lock in the wake-up time, and we have them go to bed later. People with insomnia do actually the opposite. Ask them when they wake up, they say, it depends on how I slept. So they have variable wake-up times, and their brain is trying to predict dawn and dusk. That timing mechanism in our head is simply trying to predict dawn and dusk. So we lock in the wake-up time, give somebody a later bedtime. We do that. And then they have some time in the evening now, extra time. And what we have them do is away from the bedroom, sit down with a journal, not a computer, a journal, a notebook, and write down what you have to do tomorrow. Little things. I got to go to the store to buy milk, whatever it is. Then write down the other stuff. Like, I meant to write on, we always have like these loose threads in our head. I meant to tell Uncle Joe thank you for the Christmas presents from 3 years ago. I never wrote to Uncle Joe. Just put that down. Little things in the back of your head. Again, I want to go skydiving one day. We all have these things you want to do one day. Whatever's on your mind, write it down. But after about 10 or 15 minutes, tell yourself, I'm done with my day. Whatever left unfinished, I'll do it tomorrow. Say it and believe it. Now, do something you enjoy. After you've been doing all this work, you don't just jump into bed because you've been working. Do something you enjoy. Read for pleasure. Spend time for your spouse. Warm bath, whatever it is that lets you know that your day's over. Then you go into bed. When you feel like you want to yawn, kind of hold in that yawn and then get into bed. That's what you want to do. In the morning, look at what you wrote. It's nobody's business what you wrote. I'm not going to look at it. It's your personal thing you wrote. But it's amazing how problems seem worse at night than do in the morning, right? So you look at it in the morning, your day's organized. And then in the middle of the night, if you pop awake with a random thought, remind yourself the important stuff got written down already. That's called scheduled thinking time. And the thing with these behavioral things, when you talk to insomniacs, they tend to be very cynical because they've tried all this stuff before. But usually they've done things only for 3 or 4 nights. The data, the randomized trials on doing these techniques, these behavioral techniques, if you do it for 2 months, about 80% of your patients no longer will have insomnia and will no longer take medication. And the beauty of it is that when they've done follow-up research and they contact these people 2 years later, they're still sleeping well. So sleeping is a learned behavior, and you can learn to sleep differently. Insomnia, if any way, is a mode of sleeping when the brain thinks something is wrong. And they get kind of trapped in thinking that what's wrong is how they're sleeping, and that by itself is how they dig themselves in that hole. So you can get out of that. But ask them for 2 months of your time. They say this all the time, I'll do whatever you say, doctor. I'll do whatever you say. Stay up later. I can't do that. I go, yes, you can. You have insomnia. You can stay up later. This happens all the time, every day. So you can push them. Let's talk about sleep apnea. I thought I was going to show you a different slide. But apnea is just a Greek word that means absence of air, obstructive sleep apnea. And this is a huge thing for us in interaction with cardiologists. The main reason that now, the most common reason that we get patients from other physicians, other groups, are cardiologists now. So thank you. Because now they're acknowledging the importance of sleep, and you've seen the impact of how it has. Let me go over a few things. Did I get that? I thought I had a different slide for that. Okay, let's go over that. So what's sleep apnea? Sleep apnea, people, the brain says, I prefer to sleep than to breathe. That's what it is. Think about this. You stop breathing, but you keep sleeping. For a little while, the brain prioritizes sleeping over breathing. And usually the pause is about 10 seconds. It's characterized with a blockage in our breathing. Obstructive sleep apnea. First described by Charles Dickens in the English language. And Mr. Pickwick, in the posthumous papers of the Pickwick Club, that's Mr. Pickwick right there. Bald, middle-aged, overweight guy, probably had sleep apnea, probably snored a ton. But Mr. Pickwick is not who is described as having sleep apnea, it's a child, little fat Joe. And it says on the box a fat and red-faced boy in a state of somnolency, sleepy. There's another photo of Joe there, that diagram, Pickwick. So when sleep apnea was initially described, they called it the Pickwickian syndrome because there was overweight and sleepy people. But it's a misconception to think that you have to be overweight to have sleep apnea. In fact, only about half of our patients are obese. You can be thin and have sleep apnea. These are all kids with sleep apnea. What happens is, if you're not breathing well, especially if you have a blocked nose, your face will grow in a long plane. The growth of our face is affected by mouth breathing. I'm looking at all of you nicely. All of you have your mouths closed when you're breathing. Oh, she just opened it. But if you, right, what's the stereotype of somebody who's not bright? Right? Mouth breathing, right? That's the stereotype. And there's some basis for this, because if you are a mouth breather, especially if you're a child, and you mouth breathe in your sleep, the growth of your face, the lengthening of our bones, by the way, occurs in sleep. We're not growing all the time. The physical lengthening of our bones occurs in sleep. That's when the growth hormone secretion peaks, is in slow wave sleep. That's when the bones get longer. So if you're sleeping like this, your face will grow in that plane. And early on, this is from an orphanage, these old photos. These were kids that were all said to have what's called an adenoidal face, mouth breathing. Back then, they did not know about sleep apnea. They just knew that these kids didn't do well in school. they were considered to be so, quote unquote, this is the medical term at the time, idiots. That was the term that was used to describe them. And they were mouth breathers, long face. All these kids have sleep apnea. So mouth breathing is what we're trying to avoid. Any mouth breathers is a problem, especially in kids, is an issue. Obviously, if you have a cold and an allergy, that's different. I'm talking about all the time. And in part because people knew that this adenoidal face was developing, is that there was a big push in the United States to take out tonsils and adenoids in children. And in the 1950s, it was the most commonly done surgery in the United States. Right? The trend has decreased for we no longer take out tonsils because of recurrent tonsillitis, because we have penicillin. But there's no controversy. The first line treatment for sleep apnea in a child is take out their tonsils and their adenoids. We want to get rid of this mouth breathing. This is a death certificate from 1977. And you really can't see it too well here on while it's showing up, but I blew it up so you can see better. And this is 1977. Somebody says, cause of death, undetermined. Can you read that? Possible. Big Ricken. There you go, cardiomegaly. So this gets blocked. How does that have to do with the heart? Well, when this is blocked, the heart has to work harder because there's an obstruction of the chest, and cardiomegaly can develop. So we've been talking about heart issues with sleep for a long time. And the treatment in the 70s for this, the Stanford Sleep Clinic, original one to open in the United States in 1970, the treatment was a tracheostomy. So for 11 years, the Stanford Sleep Clinic was like the top place in the country supposedly to do sleep. People came from all over the place. It was a tracheostomy clinic. You came in there to get trached. And they told you that, well, if you just want to go lose weight on your own, good luck. That a 95% failure rate. And if you had more than 30 events an hour, you had a 25% chance of dying within 5 years. That's why whenever you talk to your sleep doctor, look at your reports, they say that, what is mild, moderate, or severe? The cutoff of 30 for the apnea-hypopnea index is just based on this data from the tracheostomy data. From the people who didn't get trached, had more than 30 events an hour, 25% of them died, all-cause mortality. So that's how it was. But things have changed, and now some of the features of sleep apnea I should have mentioned. Hypertension, reflux. Little kids, by the way, when they have sleep apnea, tend to be scrawny. And the misconception is that, certainly somebody like me, overweight, middle-aged, of course, I could snore and have sleep apnea. But we see a lot of thin people coming in with sleep apnea. What you're going to look for is small jaw, the jaw's kind of back, and the teeth are overlapping, especially the incisors, because the jaw's small. It's not that they have big teeth, it's that the jaw is relatively small, and their tongue is connected to our jaw. The biggest thing taking up space in our throats is our tongue. That's the biggest thing in our throats, taking up space. And sleep apnea is simply a throat issue. It's from the Adam's apple, your larynx, to the back of your nose. That's where the problem is, because there's conflicting functions. You need your throat to stay open in order to breathe, but you also need it to be a muscular contraction in order to eat and in order to talk, laugh, or sing. It's got a lot very dynamic. So the tongues are taking up a lot of this space. And if you want to know who among you snores, it's very simple. If your tongue is wider than the roof of your mouth, you probably snore. You just look in somebody's mouth. When you look and you examine your patient, look at the roof of their mouth. I'll show you some pictures of this in a moment. By the way, the adults with sleep apnea, one of the things they'll start doing is having nocturia, getting up on night to pee. So always ask that question. They're getting up to pee, because once you treat their sleep apnea, about half of them stop peeing at night or decreases dramatically. Very common disorder. We all know people who have this problem. These are conservative numbers. In fact, when I remember the first time I went to a Cardiovascular Conference, I was just grand rounds of Stanford, and I was talking about the numbers and the impact of sleep apnea. They actually laughed, but not in the nice way like you guys are laughing. They actually laughed in a different way at me, because the numbers sound too huge. It doesn't make sense, because the effect size is dramatic when you improve how their sleep and how many people have this. But millions of people have sleep apnea. Sleeping should be silent. You should not make any noise when you're breathing. So all snoring is abnormal. All snoring implies an obstruction in your airflow. Right? You shouldn't make any noise. If you believe that there's a paradox of sleep, that animals that are sleeping are vulnerable to being attacked at any point, if you believe that is true, then why would you tip off your presence to your predators when your guard is down? And I've had patients, this is like every day at work. I'm here because my wife claims I snore. I hear every day. I say, go home and kiss your wife. She's doing you a favor, right? She's helping you. Because the people who show up that sleep alone, they usually show up at a more severe state. They say, oh, I've had this for, usually those people come in because they took a trip with their relatives or visited somebody. That's when they found out they snored. And I hear this a lot. My wife claims I snore. I'm like, why would she say that if it wasn't true, right? What is it, right? Why would they say that? So sleeping should be silent. You should be making any noise when you're breathing. A little bit of anatomy. So the blockage of the tongue, I talked about before. Normally when you're sleeping, if you're sleeping with your mouth closed, right? Imagine if you really slept with your mouth open when we slept in caves and stuff. All kinds of stuff we get in our mouths, right? Just keep your mouth closed, right? Probably that's what those hairs are probably for, now that I think of it. Filters. But if your mouth is closed, if you look at a baby, how tiny their little tongues are, that's a muscle that's going to grow. And if you sleep with your mouth closed, that muscle is on the roof of the mouth. The muscle grows, and this is all soft, and it makes space for itself. So the tongue and the hard palate are like a hand and glove, and they fit well. And that's how it's supposed to be. But if instead you sleep with your mouth open, your tongue's out of position. Your tongue's going to grow, but not make space for itself. So that's why the roof of the mouth tends to be high in these people, especially when you're thin insomniac. You're thin sleep apneics, excuse me. I have a slide on that. Can you guys make out the roof of the mouth is narrow? You see that? Look for that. Ask people to stick out their tongues. And you might see if they have tendency to sleep apnea, the tongue is too big for the space that's in. So when they stick out their tongue, you see little crescent marks of the teeth along the edges of the tongue. That's because the tongue is kind of pressed in there, right? And if I want to snore, I got to throw my tongue back. If I push my tongue forward, I can't snore. You guys want to try? Do you snore, sir? No. You don't know? Okay. All right. Sure you don't. Okay. What?
I had a sleep study,
Oh, okay.
and I was okay,
Good for you. Good for you. Now, why did you have a sleep study if you were okay, though?
because I had a car accident.
Oh,
I
okay.
slept, I fell asleep.
Oh, okay. Thank you. Okay. Thank you. Okay. Thank you. I'm sorry. Thank you for sharing. That's actually one of the most common causes of death in people is drowsy driving. And at the class, I teach a class, and drowsy driving is one of the things we teach all our college students about. We have a slogan: drowsiness is red alert. And we teach the kids, especially, remember this, when people are driving, never fall asleep. Always, people fall asleep usually on familiar roads driving alone. That's when it happens. You don't fall asleep looking for a new address. It's driving alone. And when people have passengers in the car, if you're ever the passenger, the person in the passenger seat in the front should always stay awake with the driver. It's very, very common, especially when you talk with the college students, when they do their road trips, they want to take shifts. And if you're driving and everybody else is sleeping in the car, what are you going to do? Quiet things down. You want to be a good driver, and you keep things low, and you want to be good, and you're going to lull yourself into sleeping. So that's one of the things we actually teach our college students is somebody always stays awake with the driver. Somebody always stays awake with the driver. Always. So keep that in mind. So this thing about the high arch palate is such a big deal to us. And in psychiatry, the DSM-4, I know we're in the DSM-5 now, but the DSM-4, which was a codified, this was how you diagnose ADD. If they formalized this, they said that a physical finding of somebody with ADD is having a high arch palate. That's in there. If you have an old DSM-4 lying around, maybe a book stop somewhere, door stop somewhere, look for it. You'll see that it says high arch palates are a physical sign of ADD. So these kids back then, this is an old book now. These are now your adult patients on Ritalin who have adult ADD now and stuff. Look in their mouths. You're going to see that these were some of them. The estimate's about 25% of the kids who got put on ADD meds actually had sleep apnea that was overlooked. So look for that. I mean, it was there. Insurance companies will do the home sleep testing. We're doing more and more home sleep testing. We can go back and forth on this. In the end, obviously, these are money issues. Just know this about sleep studies. Sleep tests can give you false negatives. They don't usually give you false positives. So when you look at the results, if you suspect somebody had sleep apnea and has a negative test, you cannot assume that their really test was ultimately negative because somebody may not have slept that well. You can have a first night effect, they sleep lightly. However, if the test says you're positive, it's really as positive, especially an in-lab test, because it's really hard to fake you on your own holding your breath and keeping yourself asleep at the same time. So you can get false negatives, but not false positives. So the policy of most of these insurance companies is if they do a home test to save money or time, whatever they're thinking of it, if it comes back negative, then they'll authorize a full study. You should take them up on that. Because I see many patients over the years say, well, I had a sleep test that was normal. you look at this guy and go, I know you have sleep apnea. Well, 5 years, it was normal back then. It's a progressive condition. You can miss it. So just keep this in mind when you have a negative result. It might, just repeat it, double check it. A lot of sleep apnea treatments out there, CPAP, oral appliances surgery. CPAP's gotten a lot more sophisticated. There's all kinds of CPAP now. Most of the CPAP we're using is automatic, self-adjust. There's bilevel. There's CPAP machines specifically for people with a combination of sleep apnea and central apnea. The ASV machines are specifically engineered to help people with Cheyne-Stokes respiration. So you'll see that also will help. So sometimes if you give somebody too much CPAP pressure, they actually get central apneas. They call it complicated sleep apnea. So you can now do something with these other machines. And the AVAPs are for the more overweight patients. Just miniaturize it. I saw them by the table outside. I'm not pushing any particular brand, but if you walk the tables, you'll see both of these are out there. But CPAP machines are now about the size of your cell phone. Okay, you see that one right there? They're getting better and they're getting smaller. Actually, someday we'll have better treatments than CPAP. But when we look back in the history of our field, right now we're living in the golden era of CPAP. It's just never been better. People think it's this big, bulky, noisy machine. And if your patient ever tells you the CPAP machine is making a lot of noise, I don't use it, it's not set right. Because it's supposed to be quiet. In fact, the other thing you can ask your patients, if you have sleep apnea and they're on CPAP, if they can snore on CPAP, again, it's not set right. So simply ask that question, you're on CPAP, yeah, how's it going? Oh, so are you snoring with it on? Yeah, I still snore. It's not set right. It's not set right. Surgery, there's a lot of different surgeries out there. One of my, we had a fellow one time who was a cardiologist, and they rotated with us, and she was aghast when she came to the sleep clinic. She said that we're so behind in our technology, how bad the quality of sleep medicine research is compared to cardiology research. She's right. You guys are doing better, a lot more stuff. But one thing we've caught up to you guys is now we have pacemakers. And there's pacemakers now for the tongue. And it's now FDA approved. This is not research. If the biggest thing taking up space in our throats is our tongue, you can actually have somebody get a pacemaker for their tongue. And it actually comes with a big remote control, and what it does is it's implanted, of course, like any other pacemaker, but the wires go to the nerve underneath the tongue. The tongue muscle is called the glossus, the nerve underneath it is called the hypoglossus. So the hypoglossal nerve stimulator is what we do, and it works. And this just moves the tongue out of the way with every breath they take. And you, by the way, you only use it when you're sleeping. So you turn it on when you're about to go to sleep, you turn it off. And this has happened. People have lost the remote controls and it becomes a hassle for them. Because how did you lose it? This happens. They misplaced it, they put it in their luggage, and the luggage gets lost. Things like that happen. But now you can do pacemakers for the tongue. Oral appliances also work, but the oral appliance is tailored directly to the source of the obstruction. Typically, it's moving the tongue forward. There's a lot of boil and bite, over-the-counter type things. And something from a regulatory point of view you should be aware of, snoring is viewed as a cosmetic issue. Sleep apnea is a medical condition. So you're gonna see things marketed, they'll say snoring. The photo, the commercial, anything they add, shows somebody who looks like they have sleep apnea, but they never say the word sleep apnea, they say snoring. Because that's why they can do it without a prescription, because that's viewed as a cosmetic issue. So watch out, because things that just reduce snoring, but don't address the actual obstruction, it's called silent apnea, right? They can still have all the cardiovascular complications of sleep apnea, they're just not making less noise. In fact, there was a time in the 80s where surgeons were just people cutting off the uvulas, and that made you vibrate less, made less noise, but you still had your tongue blocking your breathing, you still were choking in your sleep. And they help. They lower your blood pressure. How are we doing for time?
10 minutes. 5 minutes.
5 minutes. Let me change gears real quick for you guys. I want to talk to you about kids, because it's something I've been working on. So, turns out lack of sleep also makes us impulsive. The most common cause of death of teenagers in the United States is car accidents, number one, 2 is suicides. And both of these have been impacted by sleep. There's data showing that lack of sleep enhances suicidal behavior independent of mood. It's not because somebody is depressed. Depression has to be addressed and not to be ignored. But lack of sleep by itself makes people impulsive. In Palo Alto, we had what they call a contagion of suicides, and they were very nasty suicides. Kids were throwing themselves in front of trains. And that was in the news. It's a very impulsive thing to do. This is data from Korea. South Korean teenagers are most sleep deprived on the planet that have been measured. They have higher suicide rates there too. And this is independent of mood. They still had this problem. And it was sleeping in no more than 7 hours. United States, there's studies on this. I'm going to show you some more recent study in a second. This is the Center for Disease Control has been tracking this since 1991. Our kids didn't have cell phones in 1991. It's getting worse. Cell phones aren't helping, but you can't scapegoat the phones by themselves. Particularly look at the girls. The girls are among the worst. In fact, whenever you deal with any teenager, odds are that person's sleep deprived. Just know this, okay? Whenever you deal with teenagers, odds are that person is sleep deprived. And there are myths about sleep. People think people fall asleep because they're bored. That's not true. Boredom will never make you fall asleep by itself. Boredom unmasks your sleepiness. Boredom to the brain means you're safe. Because when you're in danger, you don't feel bored. And if you're bored, it means you're safe. And if I'm safe, I'll catch up on other things that I have to do, my housekeeping, and that's sleep. Little kids, 7 and 8-year-olds don't fall asleep when they're bored, right? 7 and 8-year-old, they like put their heads on the desk when they're bored now. They get in trouble, they do stuff. Teenagers fall asleep when they're bored. You may fall asleep when you're bored because you're sleep deprived. Monotony by itself does not make you sleepy. That's a misconception. This is a more recent paper, 2018 review, meta-analysis on about 600,000 participants, and they found that lack of sleep had a stepwise increase in suicidal behavior, suicidal thinking. And you can look at this reference if you like. Sweet spot for teenagers, 8 to 9 hours. Sleep duration is an independent risk factor for development of youth suicidality. The Academy of Pediatrics in 2014 said all high schools and middle schools in the United States should start no earlier than 8:30 in the morning. This was a push. High schools in California used to start at 9 o'clock in the morning in the 60s and the 50s. It got changed gradually over time because they underfunded transportation. That's what happened. They instead of getting more buses, they just staggered the buses and made the high school kids start earlier. But what happens biologically is when we go through puberty, there's a natural inclination for us to stay awake later. Not everybody, but a population of teenagers, when they start puberty, they shift to later falling asleep time. I told you that we have this second wind alertness. The kids have that accentuated. They go to sleep later. This is balanced, by the way, with, as we get older, a tendency to go to bed earlier. Those of you who are older will notice that it's harder for you to stay awake now than it used to be, right? You tend to want to go to bed earlier now. So it makes sense in a tribe of people for this to happen. And in fact, in hunter-gatherer societies, they found this, that the grandmothers were often waking up at night, and they thought that was probably protective of the tribe. So those of you going through menopause and complaining about this, know that you're doing this to protect the rest of your tribe, and know that you're not sleeping well. That helps you at all. But this is a real thing, that this is a shift. But other animals do this. Rodents do this. Primates do this also. When the animals go through puberty, they shift to a later bedtime. And it might be because they have to reproduce, and the babies are up at night, so it makes sense for you if you're going to be now sexually, if you can now reproduce, you should be able to stay up later if you're going to take care of a baby at night. For whatever reason, there's this real thing that happens. We have a biological shift to go to bed later when we go through puberty, which is why we just can't tell kids go to bed earlier. So this has been going on for a while. So they've shown that this has been an issue in schools. In California, the bill was proposed in 2018 to delay the start of school times. You guys heard about this bill, 328? Some of you heard about this? It passed through the Sacramento, but then Governor Brown vetoed it. It got reintroduced this year. It had its first hearing 2 weeks ago, or last week or 2 weeks ago. I was at the hearing. It passed through the committee, and it will move forward. And we're hoping that Governor Newsom, indications we're getting is that he would sign it if it goes through it. The biggest opposition, by the way, is the school administrators. School administrators say this is a local issue. You shouldn't tell us when to start. There's an exemption for rural districts. In support, every medical group that you can think of, the American Academy of Sleep Medicine, AMA, Family Practice, all the medical societies are supporting this. And now law enforcement groups are supporting delaying school start time. The California Sheriff's Association sent a letter of support in favor of this because it turns out that there's a peak in juvenile delinquency. Juvenile crime occurs after school. They're unsupervised. So this has been shown. And now they've changed several schools that have changed to later start times. The kids' grades improve, graduation rates improve, and now the schools that change, even the lower performing schools, the schools from poor neighborhoods, those schools, when they change the school start times, they equate their standardized scores to that of the more affluent neighborhoods. So this actually creates parity for people. Car accidents decrease. The schools that have done this, they've had less car accidents. So the RAND Corporation, a nonprofit corporation, just last year, 2 years ago now, put out a paper saying what would happen if California changed the start time throughout the entire state. The state would save, I think, $4 billion in the first 6 years just on decreased accidents and enhanced graduation rates. So this is something that we're hoping to do, and I would hope you guys would support. And with that, I'm sure I've used up all my time, so thank you so much.